Recording this session. Welcome to the PDIA in Action event series. My name is Salimah Samji, and I am the Director of Building State Capability at the Harvard Center for International Development. I will be your moderator today. The format of today's session is as follows. I will begin with an overview of the event series, followed by a presentation before we open up for a question and answer session. Please feel free to put your questions in the chat during the presentation. Matt Andrews and I co-teach MLD 103M, which is a field lab class where students learn how to use the PDIA, problem-driven iterative adaptation approach, by working on real-world public problems. They learn by doing. The students work together in teams with an authorizer or client who gives them the problem that they will work on. This year, we asked the alumni of our Implementing Public Policy Executive Program to nominate problems for our students. Over a 7-week period between January and March this year, our students worked with their authorizer or client to better understand the problem and to identify entry points. This event series showcases the learning of our students as well as our executive program alumni. Our topic for today's session is tackling blood safety in Nigeria. And with us, we have the student team, Allan Franklin, Dana Radojevic, Hesham Gaafar, Lauren Truong, and our IPP alumni, Dr. Adaeze Oreh, who is the country head of planning, research and statistics at the National Blood Transfusion Service in Nigeria. Welcome. I'd now like to invite Lauren to get us started. Lauren, over to you.
Great, can you see my screen? Cool, thank you for the introduction, Salimah. Hi everyone, thank you for joining us today. My name is Lauren Truong and I'm a first-year student at the Harvard Kennedy School. Today I'm joined by Dana Radojevic, who is also a first-year public policy student, Allan Franklin, a mid-career student, and by Hesham Gaafar, a student at the Harvard School of Public Health. We'll be sharing with you today what we learned about the PDIA process while tackling blood safety in Nigeria with our authorizer, Dr. Adaeze Oreh from the National Blood Transfusion Service. So I'll start off by explaining an important part of the PDIA process, the problem. Problems are ubiquitous. We run into them in everyday life, and they force us to drive change in our society. But it's human nature to be solution-driven. So instead of digging deeper and questioning what is causing the actual problem, many of us sell prepackaged solutions, and we think that these prepackaged solutions will solve the root issue. But unfortunately, as we all know, problems such as blood safety in Nigeria are complex and multifaceted. And by being solution-driven, we fail to address the root causes of the problem. So let me introduce our initial problem statement. In Nigeria, the National Blood Transfusion Service, NBTS, is not the sole blood collecting agency, and hospitals, clinics, and private blood establishments are able to collect blood donations and transfuse them to patients. The problem is that safe blood is still largely unavailable in hospitals and health facilities, leading to infection, disease, and death. At a first glance, this problem seems solvable. If we found a way to make NBTS the sole provider of, the sole blood collecting agency, we could then run campaigns throughout the country to increase the number of voluntary blood donors. But the first thing PDIA forces us to do is problem analysis and problem construction. So when grappling with this issue, we had to ask ourselves, what precisely is the problem? Even if that felt obvious, even if that felt counterintuitive at times. So in this case, we had many questions about what precisely safe blood is. Is it an issue caused by supply side factors, such as the lack of infrastructure? Or is it caused by demand side factors, such as the number of voluntary blood donors? Or is it a combination of both? Now, I'll back up a little and speak about our personal experience. When we all started this class in January, none of us expected to be working on blood safety. And three of us, Dana, Allan, and myself, do not have experience working in public health, so it was really overwhelming during our first meeting with our authorizer to learn about the severity of this issue, the complex ways in which blood is transferred from a donor to a patient, and the ways terrorism and culture impact blood donations. Hesham, who joined our team a week later, has a medical background and was able to provide great insight into how systems are structured in other countries. So through our weekly conversations with Dr. Oreh, we realized that the problem was much more complex and that focusing on increasing the number of voluntary blood donors to have a safer supply of blood wouldn't adequately address the root causes of this issue. So to learn more about this issue and to gain more context about blood safety in Nigeria, we each read several articles about this topic and were able to interview blood donors and doctors from Nigeria. So I'll pass it off to Allan to speak more about what we learned about the problem through the interviews we conducted.
Hi, thank you, Lauren. Yes, I'll speak a bit about the interviews. First thing is that we did a tremendous amount of reading between all of us, among all of us. But readings only teach you a certain amount about the problem. And this is especially the case for us who have never really been exposed to blood issues and this kind of medical situation before. What I like about interviews, and the more we did, the more we realized this, is that interviews are unique in that they give you a kind of 360 degree view of your problem. And the more people you speak to, the more interviews you conduct, the more of that puzzle you tend to fill out from all sides. And that's very important. The other thing with interviews is that they tend to provide a depth, a texture, and also a nuance that you never get from reading journals or academic material. The more you speak to people, you get their specific perspectives, you get their feelings on issues, and you get their unique takeaways as well. And all those come through pretty strongly in interviews. And the other thing I would like to add is that every interview is totally different. Every interview, even if you interview the same person on two separate occasions, each interview has a very different feel. Another thing about interviews is that, especially in terms of how we structured our interviews, every person we spoke to represented either a client, a partner, or a stakeholder at some stage in the process. And this was extremely valuable for us in terms of, again, taking us deep into the problem and giving us an insight that we would otherwise not have had. One of the favorite characteristics about interviews for me, though, is that interviews are interactive. And even though that seems like a simple thing, the ability to probe and the ability to question and the ability to follow up on certain things is very useful when tackling a problem with which you're totally unfamiliar. And I think also what's very good about interviews is that, especially for a problem like this that's going to be ongoing, interviews have a distinct advantage of building trust with your stakeholders and partners. And on many occasions, we can point to this. On the picture on your screen, you can see Mr. Nathan John. He was one of the first interviews that we held. And I'm very proud to say that we did build a very tight relationship with him. Even the process of setting up the interviews, I think we had to schedule at least 4 calls before we were finally successful. He is one of the most prolific donors in Nigeria, and his perspective comes from a totally different place than, let's say, my perspective or a team's perspective would have come. And speaking to him yielded so many insights on so many things, especially from a local perspective, especially from a perspective of a person living in Nigeria and also experiencing things from his village and through the like kind of eyes of his friends and family and regular people. That is information you hardly find in academic works or in textbooks as well. Next slide, please. Okay, so this is a broader look at the people we would have interviewed. As you can see, if you look at it closely, you can see a number of clusters. So our team, as Lauren has said, with the exception of Hesham, had very little exposure to this particular issue or even medical issues as a whole. And let me use myself as an example. For me, it all started with speaking to persons I knew in the medical field. And this was personally in the Caribbean, but also within the HKS program. So that was a start for me to kind of get some kind of context within that. One thing we did from there, Hesham spoke to his colleagues as well. And that was very useful because not only did he have a medical background and he can speak to them on a very technical level, but also many of his colleagues were situated in the region and again gave specific insight into what not only was happening in the region and also in Nigeria, but also practice within that region that could be applied to the situation as well. A big component of the persons we interviewed were provided by Dr. Oreh herself. And these were many stakeholders and partners within the process of the blood sector in Nigeria. And again, speaking with these persons kind of filled out many blanks and filled out many corners that we had actually overlooked. And this was useful because what it did for us, it allowed us to redefine and continually shape our problem statement. And I can tell you our problem statement went through a number of iterations. But what it also did was as we grew further into the process, it allowed us to kind of examine more our entry points, see how robust they were, and also test them to see which ones were most viable. So speaking to stakeholders is very important, and our project would not have come the way it is if we had not spoken to so many people. I'll now like to pass to the next speaker where we speak more about those entry points and other aspects of the problem.
Thank you, Allan. Next, so after talking to all these people representing multiple different stakeholders in Nigeria's blood donation system, we were able to focus in and refine our problem construction to what you can see in front of you. Local health facilities and organizations in Nigeria do not have the capacity to attain or maintain safe blood supplies. Compared to our original, more passive statement, which just stated that safe blood was unavailable. With this refined problem construction, we identified that the target was increasing local capacity of getting safe blood and then maintaining it through the supply chain and during storage. With a refined problem statement in mind, we continued to do our research, exploring what were the causes of this problem, and once we identified a thread, we kept pulling and asking why. Next slide, please. As we were identifying the causes of our problem, we began plotting them onto our fishbone diagram by the different sectors, which you can see in front of you. The term fishbone diagram comes from the structural appearance of the drawing. Functionally, I prefer to think of it more as a river system, with the problems as tributaries feeding into a larger stream that feeds into a mighty flowing river. The main problem streams we identified were insufficient blood screening, limited local capacity, policies and procedures, economic issues, poor infrastructure, low supply of blood, and finally, people and staff. Each of these individual problem streams is a complex and entrenched issue with multiple contributors and actors, and can seem very daunting. So how do we begin to even tackle the issue, which then seems so widespread and rooted? Well, we act where we can. Keeping with the river analogy, we wanted to build a dam to solve this very problematic river. Building a dam would require tools. Here, the tools we needed were authority, acceptability, and ability, better known as a AAA. The tools we have are not enough to dam up the mighty main river, so we have to move upstream and identify areas where our AAA tools would be sufficient to block a tributary, and this would be our entry point. Next slide, please. In front of you are the 4 entry points which we recommended NBTS should act on. We chose these entry points based on where we thought NBTS would have the greatest combined unilateral authority to act, where they would have the technical and resource ability available, and where they would be most likely to be welcomed and accepted. The combined product of the AAA is the change space, which you can see in the far right of the column. Once we identified the entry points, which had the greatest potential, we began developing strategies that would focus on building long-lasting coalitions to share in the responsibility of advocating for safe blood use and smart blood practices outside of NBTS and working with NBTS to ensure that this is an issue that remains carried by multiple people, as well as increasing targeted efficiency at NBTS. Our recommendations included developing certificate courses for health providers and personnel, incorporating smart blood practices and medical schooling curricula, restructuring internal management and communication strategies in NBTS, and having dedicated grant and networking personnel within NBTS. Now I'll pass it on to Dana to talk about some of the key points.
Thanks, Hesham. So it's pretty obvious by this point that there was a lot to learn about safe blood in Nigeria. And most importantly, we learned that the obstacles to achieving safe blood in Nigeria are multidimensional and complex. Safe blood cannot be achieved by just fixing one singular issue, such as the low voluntary donor rate. There are many large-scale and small-scale obstacles that need to be addressed before the problem as a whole can be quote unquote fixed. We also learned that the root causes of these obstacles are not easily remediable. Several of the root causes are the result of culture or lacking infrastructure in Nigeria. And these are things that can't be solved overnight or even within 6 months to a year. In identifying these potential entry points and solutions, we learned that the NBTS is already working to resolve most issues in some capacities. There were many times when we felt we were on the right track and we would go to Dr. Oreh and she would say, oh, the NBTS is already actually doing that in some capacity. All of that to say, we learned to lean on the diversity of our individual backgrounds to come up with a broad range of questions and ideas. The breadth of our discussions with Dr. Oreh and the final ideas we presented wouldn't have been possible had we not had such diversity among our team. Next slide, please. And on the subject of teaming, we also learned a lot just working as a team through the PDIA process itself. We quickly came to learn that teaming is a necessary component in getting to a final product that we could be proud of. This challenge that we were presented was enormous, and there was so much to learn in such a short period of time. And teaming helped us to lean on one another, to learn fast, and to develop these creative ideas, many of which would not have been possible had we only been working alone. And also, iteration was key. We regularly would go back and rework our problem statement, rework our root causes, rework our ideas. And without iteration, I don't think our ideas would have been as fine-tuned, as targeted as they were. A few other things we learned about the PDIA process, as Allan mentioned, would that you'd be surprised just how vast your network could be and how important it is to talk to people. By just talking about the classes we were taking and the problem we were working on, we found that so many people within our inner networks were able to provide insight on the problem. Many people who we never expected, such as our professors, our classmates, and even some of our former colleagues. And most importantly, there is always, 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 always more room to learn. It's important not to take a given problem as is, and continually asking why something is the way it is a way to make room for more reflection and introspection that can get you to a better final product. Next slide, please. So when we started the PDIA process, I think it's fair to say that all four of us were excited, but also intimidated and quite possibly terrified by just how large this problem was. And Dr. Oreh's response, we felt so perfectly summed up the PDIA process that we wanted to highlight it here. And what she said is that there is an element of fear with PDIA, which ultimately galvanizes us into action, which is exactly what we found to be true. So that sums up mine, Lauren, Hesham's, and Allan's presentation, and I think we can hand it over to Dr. Adaeze Oreh to have some words.
Thank you. Dr. Ouri, if you could share your learnings with our participants today. Dr. Ouri, thank you.
Thank you so much, Salimah and Matt, for inviting me to work with the students on this project. Now, I don't know how specific master's students were assigned to groups, but from the very first day, it did seem to me that Lauren, Dana, Allan, and then a week later, Hesham were perfect for the no bad blood group. I found myself eagerly looking forward to our weekly meetings because it was exciting having a team of people who were keen on deep diving into the problem of safe blood availability in Nigeria. And I mean, for me, this is a problem that consumes me on a daily basis. So to have people who weren't working in the thick of it, who had been thrust with this project, and being engaged with their enthusiasm and the depth of analysis that they were willing to bring to each week's interaction was something that I found very beneficial to me as a professional working in this space. So I would say that working with them was, as much as they benefited from the whole PDIA process with the project, I, as someone working on blood safety in Nigeria, benefited immensely from the process as well. So there were certain things that I learned through the process, and it was that even if possible solutions have been explored before, because I recall Dana just mentioning that there were occasions where they would proffer a solution and I'd be like, oh yes, we're working on this in some capacity or the other. It's always good to open ourselves up in the PDIA process to different perspectives. And even in the IPP, Implementing Public Policy Executive Program, which I did, this was something that really resonated with me on a weekly basis. Because when you open yourself to different perspectives and angles, you tend to try different ways of approaching those solutions. And so for me, PDIA is all about starting, stopping, reassessing, and learning, all so that we can start all over again with the lessons and the insights from the first process. And working with this fantastic group of master's students, for me, they provided enormous insights. And the insights they provided were not just from the perspective of the recommendations that they made in their final report and in their presentation, but every week, even in the questions that they asked, each member of the team somehow found a way to address the issue. And it was especially, will I say, heartwarming for me, because I knew that none of them had been directly involved in working in blood safety. I mean, aside from Hesham, who is a physician and has some background in working with patients and, of course, knowing about blood safety, but bringing their own individual experiences in their past, their present and their past roles to bear on this problem, which they were being confronted directly with for the very first time, was something that I found really, really amazing. And in the course of working with them, I would say I was pleasantly surprised by how enthusiastic the team were each and every week, especially in the second week, because the first week it was like they had been inundated with all this material, flooded the barrage of just how immense the problem of blood safety in Nigeria is. And to see them bright-eyed and eager in the second week, ready to tackle the issue, was something that actually surprised me. And so for me, the takeaway there was that even when a problem looks so enormous at the start of a project, there's the opportunity for us to tackle it with enthusiasm. And that's something that they showed me. And that optimism and enthusiasm and the depth of their analysis was something that I found very, very encouraging. Then another thing that surprised me was how supported I felt in the work that the NBTS is doing for blood safety. Just by working with such a committed team on this project, I did feel very supported and encouraged to do even more. So going forward, I'm excited at the prospect of trying out some of their recommendations, definitely, and looking forward to the networks that we will build in the course of taking on some of these recommendations, the collaborations that we will forge, and the lessons we will learn even when we fail in some of those recommendations. And hopefully, ultimately, the positive impact that will be made over time. And on this note, I would like to say that working with them on this PDIA problem and project reminded me of the quote by Winston Churchill, where he says, "Success consists of going from failure to failure without a loss of enthusiasm." And that consistent enthusiasm from Team No Blood, Bad Blood, which I told them sounded like a Nollywood movie, is certainly one of my major takeaways. And I'm very, very thankful to Matt for introducing me to this amazing team and for the rest of the PDIA community and family. Thank you so much.
Thank you very much, Dr. Oreh, for those wonderful words. It is, one thing I would like to highlight to all of our participants here in this session. This class was virtual. No one has met anyone in person. And even the version that Dr. Oreh took of implementing public policy, under normal circumstances, they would come physically to Harvard. But she is an alum of our 2020 cohort, which was it was 25 weeks online, but it was entirely virtual. So to hear these wonderful things about work that they did together and the bonds that they have built, even though none of us met each other, is really heartwarming. So thank you very much, Dr. Oreh. I'd now like to ask Matt Andrews to share some words here as well. Thanks, Matt.
Yeah, thank you so much. I think it's a really, really interesting topic. And, as we saw it emerge and kind of grow through the analysis, I think it was one of those topics where maybe the team was a little surprised at some of the issues that emerged, some of the issues that came up, where there are opportunities to act. That maybe people weren't acting on before because maybe the perception was that that people knew what was needed and they were jumping towards those conclusions. But you realize that something that you might think is logistical, like providing access to safe blood, is really complex, that there are lots of different players, there are lots of different entities, and it's actually very messy and maybe even a little bit mystical about how you deal with this. But simultaneously, there's some entry points that are practical, and that might provide some opportunities to engage. I think one of the things that was interesting is, especially looking at your graph of all the people that you spoke to, is observing all the different players that there are. And in all of the cases where we have PDIA, observing that the kinds of interventions that we're looking for, those small interventions, are usually interventions that bring people together in new ways. And I do think that in the face of a challenge like this, that has been a challenge for a long time, that seems elusive, that has defied solution, one of the things we need to be doing is finding these small interventions where we can bring players together, to work together, to learn together, to build trust together, so that they can find those solutions together. And pretty much all of the opportunities that the team has identified, I think, are in that kind of category. And I think that is one of the really common, prominent messages of everything that comes out of every PDIA team is, this is really messy. There's lots of people involved. Let's find small interventions where we can bring some of those people together and have them kind of rub their brains and their know-how together in new ways. And that was interesting to see come out of this work. So, to Dr. Oreh, thank you for your time. Thank you for committing to this work. We think that you and your colleagues who help the teams are kind of almost like practitioner shepherds, helping people to see what the world of practice looks like, giving them, trusting them to engage, to talk to people, to help you. And to the team, thank you for being willing to climb that mountain, when you didn't know what the mountain was, when it was really tricky, but being curious, being determined, and being dedicated to a problem that is far away from you, but that you very quickly owned as something that mattered. So, Salimah and I often talk about how wonderful it is to connect the executive education part of the Kennedy School with the degree program part of the Kennedy School, with what we think is kind of like maybe just the magic of a simple process like PDIA. But none of that would be possible if you guys weren't just so committed to doing this work. And so, you know, that's my gratitude to all of you for the attitude and the care and the dedication you bring to this work.
Great, thank you, Matt. And I just wanted to add for the students, because Dr. Oreh, being an alum of the IPP program, was very aware of what was going to happen in the process. But I think for the students to trust us, our team No Bad Blood, and trust in the process, despite feeling like they were thrown in the deep end, was really helpful and allowed them to learn and see how the process plays out. With that, we're going to move to a Q&A session. If you could use the raise hand feature in Zoom, and I will take 2 to 3 questions at a time, and then have the student team as well as Dr. Oreh respond to your questions, and we can start with that. I actually wanted to start with my question first. And my question to both the student team and to Dr. Oreh is, what surprised you? And each of the students it can be something different. What surprised you through this process? What was the thing that you least expected to come out of this process?
Okay, I think I'll kick off first. For me, it was just how enthusiastic everybody was. And I would say, I think I hinted at this when I was speaking earlier. It was the very first week when they were kind of putting together in their minds what the problem was. I was filling in on some of the questions they had. They started reading through some of the links that Salimah had forwarded to them to kind of get their heads around the whole blood safety issue in Nigeria and in Africa. I think I expected that in the second week, it would be a struggle. I expected to see downcast faces and just generally trudging on and struggling through this problem that has the potential of saving millions of lives, but hey, let's do this. It's what PDIA is all about. But just to see them in their authentic selves, confronting the problem with enthusiasm, ideas, questions, probing, exploring, that for me was what was most surprising. The fact that in the face of an immense problem, people who hadn't been directly involved in working in that space were so interested and so enthusiastic about putting themselves out there, learning through the process, and possibly coming up with workable solutions. So that for me was something that was most surprising.
Thank you.
I guess I can speak up, and Hesham, Allan, Lauren, please follow me up with anything that you may have. But I think what surprised me the most was just how crucial the teamwork was in developing these diverse ideas, and even not even just developing the diverse ideas, but just sparking diverse conversations and lines of questioning with Dr. Oreh, because from a singular mindset, you can think, okay, I'm in the right direction, I'm going in the right direction. And then, you know, I might be leaning one way of, oh, we need more funding for the NBTS. But then Hesham would ask a question, you know, about the medical schools, and that would take us in an entirely new way, and would make complete sense. And that was something I would never in a million years have thought of. So just the diversity of thought that came from 4 students, with very little background on this is really what surprised me. I think going into this thought that we might all kind of navigate towards the same ideas and the same solutions, and that was absolutely not the case, for good reason. And I think our product came out of that was much better and stronger for it.
I can go next. Oh, Hesham, you want to go? Oh, I can go next then. For me, what was surprising is that the lesson that the faster you go, the more you learn, and the more you learn, the better it is. That was very interesting for me. The idea that every week you tackle another segment of the problem and you keep moving and you keep moving and you keep moving. I think that's something that was surprising for me in such a small space of time to allow us to do what we did. And it's a lesson that I'll take with me moving forward from this class as well.
So I'll go next. I think what surprised me was a combination of what Dan and Allan said. I was very surprised at sort of the diversity of opinion. I remember when we were first assigned the topic, thinking, oh, this is health related, this should be easy, I'm well aware of it. And then actually digging deeper into it, you realize how siloed one's thinking is and how the diversity of perspectives actually shows you how far reaching the problem is. And then how fast things adapted and changed was also very interesting for me. Looking at other projects, how long the time scale is usually given. It's several months to get some information and then several years to try and implement it. And just how rapidly solutions were coming up at the end with the PDIA process was very interesting and surprising for me.
Yeah, and I think to just finish it off, I think what really surprised me, as someone whose family my parents never went to college, so they didn't really have such a big network. What surprised me was the amount of information people know. So I would talk about PDIA and the project that we were working on with a lot of my friends, who then connected me with other people who knew much more about this topic. So my biggest takeaway is that there is so much learning and that we can always continue to grow. And it was really exciting to see, just like to meet with the bigger group every week to share what we've learned the past week, and also to make those connections and have more conversations and drive the process forward.
Wonderful. Thank you very much. We're now going to open to the questions. We had a question that came in the chat from Hardik, and we have a question from Angela. Hardik, would you like to voice your question?
Sure. So the question for this panel is, what was the basis for the researchers to contact the interviewees? Were the interviews doctors, citizens in affected areas, blood donators like the example of Mr. Nathan John, intersections between all of the above categories, or was it a different basis altogether? How was the interviewee selected? Thank you.
Allan, Hesham, since you two conducted the most interviews for our project, do you want to talk about how you ended up selecting the people you ended up choosing?
Yeah, sure. I can start with that. Well, we were provided with some interviewees from Dr. Oreh to start with, and we utilized those as best we could, and those were really helpful. But also from our own end, there are 5 of us, and we each started with our internal networks. We started at HKS and gradually worked out. And I think that's the meeting of those two methods work very well, because we got a wider diversity of people to speak to. So like, for example, I approached the problem from a totally different perspective than Hesham did. And I think when we all came together, we got a very diverse set of views. So there was no, that was the strategy we used, I believe.
I think, yeah, reiterating what Allan said, I think the selection of interviewers were based on our network and our current position on the problem. So for me, I started off looking at sort of physicians and people who are interested in sort of blood interactions, particularly in Nigeria. And then that sort of grew. So when they talk about perceptions about the public, then I started trying to contact people in the public in Nigeria who are not related to the medical field. And that sort of grew with that way.
Yeah, as we spoke to persons would offer up or recommend someone else, and it just snowballed from there. So we just got more and more people.
Add on to what Allan and Hesham said, I think a lot of our interview requests were based on our line of thinking at the time, and that changed, and that's why you see such diversity among the people who we interviewed in that snowflake diagram. We started out with a medical track, but then we would start working down a track of, okay, how can we fix this on a local governance level? And that led us to speaking to some NGO experts here in the United States. So that's how you see such diversity among the people we researched. And I think a large part of that was just following our trains of thinking at the time and reaching out to anyone and everyone who would talk to us. And then those people would spark more additional trains of thinking. And so that's why it expanded from there.
Great, thank you. And Dr. Oreh, maybe you could say a few words about how you decided on the first list that you gave them of stakeholders that they should speak to.
Yes, so thank you, Salimah. I remember when you reached out about coming up with a list of possible interviewees who the group could speak to. The first thing I realized was I was coming from the National Blood Service, and obviously we're the organization that is right at the center of working on blood safety in Nigeria. So in addition to myself, I also provided the details of our national coordinator, but realizing that his perspective would also be similar to mine because we're coming from the same place. I also wanted the team to have the opportunity of speaking with those who regularly donate blood, realizing that they are members of the community, they have families, they have friends. So in addition to being part of our resource in terms of collection of blood, they are also beneficiaries of a working system for blood donation in the country. And so that's how I provided Mr. Nathan's details. In addition, we have stakeholders who we've worked with over the years, working on training of the blood service and hospital staff in terms of blood collection, blood donation practices, screening of blood. So I also provided some individuals who were coming from that place as well. Then we also work in communities. So I recommended people who they could speak to from the community perspective, people who are used to working on public advocacy for safe blood, even down to the primary and the secondary schools, just to start helping with reorienting the community about the need for safe blood. So I tried as much as possible to give a diverse, but then again, I was coming from IPP, I was coming from some knowledge of PDIA and what it involved. So I knew that for their interviews to be as strong as possible, it needed to be as diverse as it could be. And I tried not to restrict those recommended interviewees to any particular sector, just so that they could get a broad-based view of the problem in the country.
Thank you. I'll now take a series of 3 questions. So we'll have each person ask their question and then the panel can respond. Angela?
Hi, everyone. Hello. All right. Hello, everyone. First of all, thank you so much for this conversation. It's actually quite interesting, all that what the entire conversation has been about. And I'm happy that we're having this conversation, and great work to Team No Black Bad Blood. My question is concerning the possible impact of having a platform or a situation whereby the blood donors, or there's a pool of blood donors that are directly connected to recipients. So you don't necessarily have to have, I don't want to say like cutting out blood banks, but in a situation whereby we're able to directly connect the recipients to the blood donors, how far would that go in ensuring that we have safe blood for the community?
So I think I'll take I'll take that question, and that's a great question, Angela. Thank you so much for joining us and engaging this afternoon. To some extent, that is being done at the hospital levels, where the hospitals have some registers on regular blood donors, similar to what we have at the National Blood Service. And when surgical procedures or needs for blood present, the patient, usually represented by family or a support network, would then be put in direct contact with a possible donor. But that presupposes that, one, you have ample notice about the need for blood. And so much of the challenge we have is not so much for, even though it is a problem for elective cases, which are hospital procedures that are planned for. But then when it comes to those emergency procedures, Nigeria is one of the countries with the highest burden of road traffic accidents. And I mean, now with insurgency, conflict, inter-ethnic conflict, and just violence, tribal violence, you can see that there's a jump in the emergency need for blood. And so even when those networks, we do explore that with the National Blood Service, and some hospitals do the same, the timing is usually off when it's in an emergency setting. And then when you also consider the fact that blood is usually typed, so you would need a donor with the same type linking with the patient of that same type, it can get very logistically challenging, especially in an emergency setting where you would need hundreds, thousands of blood units. I remember back in 2011, I was the team lead for the emergency response when the United Nations headquarters in Nigeria was bombed. And we had to mobilize as much as over 100 units of blood just to save the lives of those who had survived the bomb blast. So in that kind of setting, it's usually difficult to have a matched donor recipient process, but there are facilities that actually take that into consideration and use it at a small level, especially when the procedures are planned for.
Okay, thank you so much for that. If I may, real quick, I really don't want to take up too much time. But the reason I asked that question is because I'm the Chief Operating Officer of JDI, that's Jealous Development Initiatives. And we have this artificial intelligence called JBlood Match. What it does, in essence, is that it links blood donors to recipients directly based on their blood type and location. So it's live in all 36 states of the country. It's attached to Telegram and Facebook. But then the thing is, and we've seen it work already actually in Abuja, which is where we are headquartered. And we work with NBTS here in Abuja. We run blood drives with them. But then the reason I asked the question is because we already have this solution. It's already working. We're already seeing the impact of the solution, but we're also asking ourselves how it might contribute to conversations like this, where we're talking about safe blood and how it can be replicated, not necessarily replicated, but adopted, yeah, that's the word, adopted across the entire country on large scale, such that, because irrespective of whatever state you find yourself in across the 36 states, and of course the FCT, it is accessible as long as you have a smartphone and Telegram and Facebook. So that was why I asked this question, just to see how it can contribute to this entire conversation.
Yeah, Angela, yes, I remember when we had our last meeting, I think before the lockdown, and we were talking through the whole process. What it also highlights is the need for us to address the digital divide in the country. We can't run away from the fact that almost above 40% of our population don't have access to the technology that is required and is virtually commonplace in a large proportion of the world. And that technology is very viable. It's the potential for scaling is immense and it's workable, but we have to be intentional and actually look at how we can get the technology adopted across board, because it's not just about blood safety and it's not just about the JDI technology, but it's about addressing the fact that a large proportion of our population don't have access to the technology that they need. So of course, like I said the last time we met, I commend you for what you're doing, and there is enormous potential to scale.
Wonderful, thank you. I'd now like to call on Dr. Temi Dayo to ask his question, and then Katya to ask her question as well.
Thank you very much. Can you hear me, please?
Yes.
All right.
Thank you.
It's quite interesting. First, let me congratulate No Bad Blood Group team. I think this is a very complex and very ambitious project that you embarked on, and the insights that came out from your findings are very useful, particularly to me as a researcher as well. So the question I want to ask is, did you find out any issues about inefficiencies in the blood supply chain? For instance, yes, we know there is limited blood availability, people are not donating, but even the few blood that is available, if it is not used in an efficient manner, you're going to have a lot of waste in the hospital. And also, if hospitals, for instance, could have visibility to what is available in the inventory in different hospitals, right? You know, they could actually tap into those banks. So did you come across issues relating to, you know, blood wastage or inefficiencies in inventory in the hospital? Because this is another problem that might be of interest, particularly to me as a researcher.
Thank you very much, Dr. Temidayo. I think I can take this one. We actually identified that as one of the issues was with the problem of allocation and wastage. And that was our focus with our process with the certificate course to increase sort of the administrative capacity and logging of the blood units and making them available and sort of more transparent. And the second part, we're including it to the medical curricula and teaching providers. So I think the practices are called smart blood practices, where you're able to have the similar outcomes for lower blood use. So whatever low resource we have, we're actually making more use of it. So thank you very much for highlighting that point. And I think we were thinking along the same lines.
Thank you.
Okay, and our final question, Katya?
Thank you, and congratulations to the team. It was a really interesting presentation, and really appreciate your work on this. My question is around the role of culture. I think a couple of you hinted at it in your presentation, but I'm curious what the role of culture and kind of social perceptions around blood donation were in the country. What did you learn about that, and how did that inform some of your ideas and recommendations?
Sure, I think I can start, and then feel free to chime in if you have anything to add. So when we first started talking about culture, the culture of blood donation in Nigeria is very different from what I think many of us are used to in the United States. So we read a lot of papers and learned from Dr. Oreh that when people donate blood in Nigeria, they typically donate it because a relative or an immediate family member needs that blood. When you start asking for blood donations, for someone to donate blood to a stranger, it's more difficult for Nigerians to donate in that sense. And one of the things that NBTS has been working on is a communications campaign that makes blood donation much more personal. So instead of showing infographics about just the data and the raw numbers about the lack of voluntary blood donors, the stories are becoming much more personal, and by connecting blood donations to a person, Nigerians are much more willing to donate blood. And yeah.
I can just quickly follow up on Lauren's point. So in my part of my presentation, I mentioned that there were so many times when we would go to Dr. Oreh with an example or an idea, and she would say, oh, we're actually working on that in some capacity. And this is actually exactly one of those times when she said that to us, because we thought, okay, if the culture of donating blood in Nigeria could be improved, how about we improve the communication strategy? And that's when Dr. Oreh informed us that the NBTS is already working on this storytelling narrative of communication. So the NBTS is working towards this. And we obviously, knowing that they were already working on this, didn't have much to suggest, obviously, on improving the cultural aspect of this. But we did, one thing we did recommend was potentially just identifying an external consultant with international expertise on storytelling communications, just so that way NBTS could potentially improve their efforts even further.
Great, thank you. That brings us to the end of the hour, and I can give you some few minutes back from this event. Thank you very much to Dr. Oreh for agreeing to work with our students, for the support that you have provided our student team. They could not have done this without you. Thank you to our students who have learned so much, but who really tried and trusted us in the whole process of learning PDIA, and in the process learned so much, and really formed a team that worked very well together. Everyone loves the name. I think they had the best name, No Bad Blood. So thank you very much for all that you have done as well. Thank you to all the others who have joined us today. Our next event, as you know, this is a weekly event we will have every Tuesday at noon. Our next one will be Tuesday, April 27th at noon Eastern time. And the topic will be police and community relations in Lancaster, Pennsylvania. Thank you very much and have a wonderful rest of the day.